Welcome back, everyone, to another episode of the Health Optimization Medicine Podcast. I'm joined here by Jodi Duval, Dr. Alan Bookatz, Dr. Ted Achacoso, and tonight, well, we always have a doozy for you, but tonight we're going to get into the future of clinical intelligence, pattern recognition across networks rather than single biomarkers. Now, before you click skip, I want to just fully disclose that there is a simplification exercise here in what that all means, right? And what we're going to talk about today is more or less looking at lab results. And we've all received lab tests, at least if you're listening to the podcast, I assume you received lab tests before. Alan, you've got your lab test before, right? You're not just sort of going naked here, are you?
Once or twice. Well, you don't see really below here, so.
Yeah, continuous whatever monitor. Yeah,
it's
exactly.
Pants off
Leave it.
podcasts.
Yeah, okay. And Jodi's already checking in with her. I was going to say ankle bracelet, but that's probably something else. Anyway, so what we're really talking about here is looking at lab tests in the context of the whole rather than a single biomarker. For example, if you have a vitamin B12 that is, let's say, low, does that mean your entire vitamin Bs are screwed? We don't know. There's a question mark. If you are adjusting for a low vitamin D, do you need to also think about A and K? And so we're going to get into this idea of networks within the body. And since I mentioned the N word, networks here, let's talk a little bit about this, guys. You know, the body does have various networks that some people are familiar with. Some people aren't. Who wants to introduce the idea of some of the networks within the body?
Wait, before you do that, I think there has to be a core definition of what a network is, or even just what a network has, right? Because in general, what a network has is actually nodes, which are the points of connection, and then the edges, which are the connections themselves, right? So a single biomarker, for example, is just a node, right? It's just a static snapshot in time of a particular value. And in the future of clinical intelligence that we're talking about here, what's the dynamic flow of energy and metabolites between two nodes? So, for example, if you're, as Boomer said, how are these different B vitamins related to the B12 vitamin? And not only that, how is the B12 vitamin, for example, related to the colon cells that actually are involved in the metabolism of B12, right? So here we're looking at nodes and edges, which are the two things that we will remember from a network, right? That's why I always say you touch one node, it will affect the other because there are edges that connect them, or those are the relationships, right? That you do. So when you're looking at tests that we're talking about, these are clinical metabolomics tests, right? So what happens there is actually, for example, in illness medicine, you could get just a high LDL, for example, or a high fasting glucose. But that's just really a node, right? How is it related to something else? So looking at its relationships, like getting a Google Maps, for example, of the entire of the positions of all of these different nodes in a network, right? So that's sort of like the fundamentals of what a network would be like.
All right, so we've got the fundamentals of the networks. I need some examples, guys. Dr. Ted did just touch on a few of these, right? And we talked about nodes within networks, but give us some core examples of, when you're looking at lab testing, what are some of the networks that we're analyzing? And Dr. Ted just mentioned metabolomics. We also can go into other networks as well. So I'm going to volley it over. Jodi, Alan.
All right. Well, I can input here while Alan's having a think. So the most common, I go through quite a lot of blood tests per day with my clients, and what I most commonly find myself feeding back to them is when we're analyzing, obviously normal bloods, we do full blood counts, but then sometimes there's things that are missing as well. So some of the networks that I look at is surrounding inflammation and cholesterol. And so looking at, markers associated with that. And what I find is missing, and I think this is not more of it's a network, but also other associations of how we actually have to see this in a network when we're actually measuring optimal ranges and actually, not making diagnoses, but assessing where we need to be optimizing certain systems. And so the most common I find is clients will come to me, general practitioners have mentioned that their cholesterol is too high. And, we obviously look at the markers associated with total cholesterol. We look at LDLs, we look at HDLs. And what I see is evolutionarily, over time, the LDLs, if going up, obviously that is also an inflammatory marker. And we also see it in relation to other components. And now it is also seen as a highly protective marker in the right context. But HDL over time will also go up. So there is this protective mechanism evolutionarily that goes on that I've noticed with clients. We also have to consider that cholesterol going up as we age is also a natural hormonal shift that goes on. So the hormonal network. So, it's all within that context. Then we also have to look at high sensitivity CRP in relation to cholesterol. So that's another component of the network. Then we also have to look at homocysteine, which is another component of that network. And then when we've got homocysteine, that is related to folate and B12 as part of that network. And so if we don't have, optimal levels of B12 and optimal levels of folate, then we also don't have optimal levels of the homocysteine marker. So I think, obviously we've talked about this a lot in these podcasts, is that we can't singulate certain biomarkers. We have to look at them in network ranges, even across the blood tests that we can get simply, not just in clinical metabolomics.
Short, what Jodi is actually saying is we don't have single biomarker bodies,
Yeah.
right? So we have to stop practicing single biomarker medicine, right?
So
Does
I
that-
want to talk about, can I talk about single biomarker medicine? Because we have somewhat of an expert here on single biomarker medicine. And so,
Yes.
Dr. Bookatz here, and I'm just picking on you because you're still tied a little bit to the conventional system, which does have many good aspects to it, particularly the area that you work in. But let's talk a little bit about single biomarker medicine, how this is handled within a conventional illness medicine system.
Yeah, I'd say something very common that we see is glucose, right? Everybody, you can see there's the fad these days. We're all worried about what's our sugar look like. We can even see people are chasing this with getting continuous glucose monitors. And I think it's really great in that it might help with motivating someone to have better choices for what type of food they're eating and their lifestyle and activity. But I think what we're trying to do is ultimately we are trying to cosmete, right, or make look prettier a singular lab value that may not be the sole answer in itself. And so what you'll find is that people become ongoingly frustrated that they may not be making changes in their glucose because they're tracking this singular marker day by day, moment by moment. And these are, again, let me just qualify, these are clients or patients that are not type 1 diabetics where they do have a functioning pancreas, although one would argue it's probably a stressed pancreas. And so when we talk about networks, one of the things that we don't really talk about or learn about in traditional medicine is the connection between various systems such as the pancreas and the thyroid. And when we have metabolic stressors, then we can actually have the effect of one being strained and stressed affecting the other. And so for any of those that are listening, hypothyroid physiology can actually worsen underlying insulin resistance. And that will show up in the liver and the muscle and the fat. And someone that is looking at just that singular marker might say, wow, we got to get this person to exercise more, eat more healthy, restrict their glucose intake, put them on these large fasting regimens. But what's really happening is the pancreas is just trying to compensate with more insulin output. And then it's continuing to strain these poor beta cells over and over again until essentially they are effectively burnt out, right? And they're unable to keep up with the demand. And so if we maybe step back for a moment and say, we know that there is this correlation of the pancreas and the thyroid system. And if we teach them as a network, not as two separate entities, then we can see that maybe insulin resistance isn't just a glucose problem. And that if we look at the thyroid, well, while it is associated with insulin resistance, it is also the main driver of our metabolic basal rate, right? The rate in which we burn our basal metabolic rate, as well as our overall metabolism. And so, again, without going into a lot of mechanistics here, let's, instead of looking at a singular marker and chasing that gland or that organ system, let's step back and say, what else is connected to that organ system? And look at all of them in a whole and ask ourselves, how do we support all of those organs together? And then let's step back once we do that, and let's watch things as they improve.
Alan is actually talking about two things here that are important, right? The first one is that, the biomarkers that we check in illness medicine are disease biomarkers, right? These are disease markers. So they usually say that, hey, the body's already crashed. In health optimization medicine and practice, it's like, no, this is telemetry. Like, oh, your B12 is running low, or your alpha lipoic acid is running low, right? It's not saying your system has crashed. The second thing that Alan actually made a point here to make, which is, if you were listening between what he was saying, this is actually very, very important in evolutionary medicine, right? It's that what is actually being said here is that all of these changes, the disease markers, etc., are the body's adaptation. It's trying very hard to right itself. And this is a product of its adaptation. It is not a symptom. It's not a disease. It's not a sign. It's all it is the body is trying very hard to right itself. And it just, it's probably right at the cellular level, but it's actually wrong at the organismic level. So you see here, because the drive is always to survive and reproduce, right? At all levels of the body. So, but what that particular fitness function may be due for the cell, it may be right for it, but it's not right for the organ. It's not right for the entire organism. So those two are very important things. A disease biomarker is already a marker that shows that the body is already crashed, right? And the second is that is not a disease biomarker really. That's an evolutionary adaptation of the body trying to right itself at a particular level that it knows how to right itself. So those are two very important things that he made a comment on.
I want to talk about a very popular biomarker right now, and particularly for males who may be my age or approaching my age. And it has a whole cult following, and that's testosterone and testosterone replacement therapy, right? Perhaps just throwing out a question there is, can you overhaul one biomarker in this case and get a ton of results? And then what are your risks?
You cannot touch one node without affecting other nodes. That is true. That's why I never do testosterone replacement therapy. If you want that, I refer them to a urologist and let the urologist deal with all the side effects of that, right? When I do hormone balancing, I balance all the 7 neuroendocrine nexuses of the body, right? If you tell me that you just want TRT, then go somewhere else, right? Because testosterone will affect everything else, right? And it's not only that single biomarker that you want to look at the testosterone levels, the total testosterone and free testosterone, for example. You also should know that testosterone has a 24-hour dance, right? And more recently, we know that testosterone actually has a 2-week cycle. If the women have a 28-day average menstrual cycle, the males have a 14-day testosterone cycle. So you could see here that all of these things actually play into that value that you're looking at. So if you're not testing everything else, right, then that are involved in the network, then you're basically just putting the body off balance, right? So that's the way I take a look at it in terms of the body being the network. And that should be the new a way, really, with all of the information now available to us on how things are connected to each other. That should be the way, actually, that medicine should be practiced, even illness medicine, right? Is taking a look at the patterns. And now they're seeing, like, for example, giving particular drugs at a particular time affects, and this is in illness medicine. It has a different effect on the management of the disease. So it's like, and for us at health optimization medicine, like, what's new, right? So these are realizations that are having now, because
Wait,
they've always been after the quelling or increasing certain biomarkers according to what they think is should be for the particular person, right? Like testosterone.
So what I'm hearing now is that I shouldn't just try and take my testosterone to 1800. Is that what I'm hearing? What would I mean? Just out of curiosity, I mean, aside from the fact that I'm gonna have like a raging erection all the time, like what else is gonna happen to me?
Well, it's just the body is, our definition of health in health optimization medicine is that is a balance between anabolism and catabolism according to the life cycle of the organism, right? And so when you're just giving testosterone alone, you're just upsetting the anabolic balance, right? So you're basically, what's your catabolite? How are you going to induce a balance when you're constantly upsetting that balance, right? If you're a bodybuilder, good, upset that balance, right? And watch your immune system drop anyway, because the energy is then being pushed towards building all the time with no energy left for you to protect your body. Ever notice, that bodybuilders, when they're about to show themselves in October, when they grind out the stage, they would like have all those sniffles, have all the colds, etc. That's because energy has been shunted away from defense and into anabolic growth and inflammation, right? Because growth requires inflammation of the body. So you could see there that these are the consequences of not balancing, right? You got to 1800 and then you find yourself actually getting quite sick, in the process.
All right, beautiful.
I just wanted to add here, Boomer, is that for practitioners out there and maybe not yet learnt about the different nodes and the way to balance all these nexuses. But I think it's an entryway, and I find this a lot where males will come to see me in clinic and they, do all their labs, and we see the testosterone's low, and it's a motivator for them. I'm like, right, this is low. Now that's just the start. That's just the tip of the iceberg. What else is underneath this, and what else is out of balance? So I think we can look at it in a really motivating way for clients, and to have them see that, and then you aim at a higher level, but we're actually working on multiple different levels, and the explanation of where all that impacts, and that actually gives them insight into how they're feeling. Because if they've got low testosterone, then all these other components are going to be suboptimal, and so then you can work from that. So I think that's a good point to make.
Amazing.
Well,
go ahead.
But the point here that I want to make, Boomer, is that in illness medicine, which actually originated from trauma and acute infections, right? You're looking at these are easy things to monitor. But when you're looking at chronic illness now, you cannot actually ignore the fact that all of these different nodes are related to each other. All of the different markers that we're looking at are related to each other. And there is also a distinction that I actually like to make often to my patients, right? Yeah, I tell them, your illness medicine doctors, your specialists, they look at your disease markers. Here, in health optimization medicine, we look at your health markers, and look, they are different, right? They are a different set. There is some overlap that you look at, but then that there's your health markers. This is also my argument against lifestyle medicine, right? Because lifestyle medicine actually prescribes lifestyle according to the performance of your disease markers. Again, your disease, not according to your health. That's why if you have like 3 diseases, right? You have 3 different lifestyle prescriptions for you, which is totally fucked, And so, it's not really the way you want to do it. You want to have one comprehensive guideline for the lifestyle of your patient or your client. And you want that all integrated, and you want the health markers to drive it rather than the disease markers, right? You have to let the health markers drive that, and the disease markers will actually behave themselves if you address your health markers first. Because which is more plentiful, the diseased cells in the body or the healthy cells in the body, right?
Depends on who you're talking to.
Well, depends on the brain cells too, right? And depends on the organ. I'm kidding. And use brains actually have a higher value, right? So I'm sorry.
All right. So, look, we've outlined a couple of things here, and I just want to summarize key points as it relates to health optimization and health optimization medicine. First, what Dr. Ted just elucidated was differentiating between disease markers and health markers. You know, you go to your illness medicine doctor, they're going to look at disease markers. Your health optimization medicine practitioner looks at health markers. One of the things that Jodi brought up was the idea of biomarkers and using those as motivation. And this is one of my favorite reasons for continually testing every 6 months or so, even more frequently, is because it helps get client motivation, or yourself if you're looking at yourself. For me, seeing my own metabolomics results gets me motivated to get back on track if, you know, you slip off and have a birthday or something and everybody orders you cake. Another thing that Alan or Dr. Bookatz really highlighted was this singular relationship around glucose and making sure that as you're thinking about glucose, you know, what else is a part of that network that makes the glucose show up in the way it does above 126, let's say. But yeah, again, fascinating conversation here about the networks in the body. And as I promised in the beginning, this isn't too scary. It really shouldn't be super scary when we start talking about networks, because unlike, you know, sort of illness medicine, where you find an additional marker and you look for perhaps a prescription, which is fine and part of disease management, here what we're looking at as markers is a part of a network. And networks aren't overhauled with one, let's say, interjection. They're balanced. And yeah, anything else we want to add, guys, or should we wrap things up here?
I have prepared a beautiful wrap-up speech for this because we were supposed to record this last time.
Okay.
Would you like me to wrap this up?
Okay, wrap it up.
Right. For the last century, medicine has been an exercise in deconstruction. We broke the body down into organs, the organs into cells, the cells into isolated biomarkers. We became absolute masters of the parts, but we lost the whole. The future of clinical intelligence is the era of reintegration. It is acknowledging that a shift in the exosome instantly changes the gut microbiome, which alters mitochondrial bioenergetics, which shifts the epigenome. You cannot pull one single thread of human biology without the whole web vibrating. The doctors of the future won't be mechanics replacing single spark plugs. We will be systems ecologists. And that is the shift from illness medicine to health optimization. Thank you.
Mic drop moment. Mic drop moment, everybody. I love it.
Wow.
All right. For those tuning in here, if you're watching this on YouTube, please click like, subscribe, leave a comment. Let us know what you think. Did we dance around the complications of network range shifting very easily, or can we do it a little bit better? Let us know. We read every comment. If you're listening to this on Spotify or Apple Podcasts, please leave a rating and a comment. And thank you, ladies or lady and gentlemen. We'll talk to you guys next time.
Bye.